Good afternoon, everyone. Thanks for joining us. We'll give it a minute or two here to get everyone into the room. Good afternoon, everyone, again. Give it another minute here to get everyone into the room. Good afternoon, everyone. We'll give it about 30 more seconds to get everyone in the room here. Good afternoon, everyone. Thank you for joining us once again for our weekly Wednesday webinar series. Today's webinar is on the WFH Humanitarian Aid Program. My name is Brett Spitali, and I'm the Vice President of Advancement here at the National Hemophilia Foundation. At any point during the webinar, if you would like to ask a question, please use the Q&A feature at the bottom of your screen. We have NHF staff members monitoring these questions, which we will pose to our presenter after the presentation. This webinar is being recorded and will be available to the community beginning on Friday, April 16th. I'm joined today by Dr. Assad Haffar, who is the Director of Medical and Humanitarian Aid at the World Federation of Hemophilia. Thank you so much for taking the time to join us today, Dr. Haffar, and I will now turn it over to you to get us started, sir.
Okay, thank you very much, Brett, for this introduction. And I'm really very pleased to be with you today to talk about the World Federation of Hemophilia Humanitarian Aid Program. As Brett said, my name is Assad Haffar, and I'm the Medical and Humanitarian Aid Director of the World Federation of Hemophilia. I've been with the World Federation so far for 21 years, so it's been a long time that I worked with this program since the beginning. Just to let you know that we have a few patients here, information that is going to be for sure made to the NHF, but it's a confidential information. I've prepared a very condensed agenda to talk about the program today, but mainly we're going to talk about the history of the program and then our KPIs that we are now gathering. More about the COVID-19 and how it affected our program, and for the future, what can be done. So I'm going to start, first of all, with some historical background. We started the program in the year 96, in fact, but the donations were very ad hoc. We didn't have any control about these donations. We never knew how many units we were going to get, what is the shelf life. Everything was completely random. So just for people to get treated by donated product, they needed to bleed when really the product is available in the country. And that's how we used to do. So during our visits to some countries, we used to carry with us in our suitcase some product, give it to the treatment center in order to treat them. So this you can see here, for example, during exactly this photo was taken 20 years back during a visit that I did to a country in Africa called Eritrea. I carried with me some product that was given to the doctor there. And by chance, somebody had a motorcycle accident, came to the hospital that was treated. Of course, this left, because there was no treatment, with a lot of disabilities and problem about the patients. And I'm going to show you here two short videos about two patients, how they, one from Vietnam and one from Nigeria.
More? And then ended up spending 2 weeks in the hospital. So he was one that had, I think, his wisdom tooth extracted, and there was no
that's great.
drop of blood. Yes,
So as you can see, because there was no treatment, really patients suffered. And this will give you an idea about how our donations since the year 96, you could see that it's always up and down, up and down. So we couldn't really plan anything with our countries, recipient countries, if they want to have any program like prophylaxis or surgeries, because suppose that we based our estimation on this peak here that happened in 2004, and then you will see that it dropped directly in 2005, 2006. And that's what I mentioned, we didn't have any control over our donations. So it was always up and down, up and down. And again, this is how people left in many countries. So you will see here a child from Cambodia, a child from Yemen, and a child from Myanmar in Asia. That reminds me of this photo. Everybody from the community knows Prince Alex of Russia. This was taken in 1916, and you will see always he had this contraction, the flexion contraction in his left knee. In 2015, I saw this child from Mali who reminded me exactly of this photo of Prince Alexei. So I put them together just to say, in 100 years, really, nothing changed in the developing world regarding that. And what was the effect on the patients? The patients felt isolated, left with no hope, faced several social and psychological problems. And of course, the majority were unemployed. And even they lost trust in the international hemophilia community, like us, like the World Federation of Hemophilia. Now, do we really need a humanitarian aid program? I'm going to just give you, this is a question that I posed, and I'm going to give you an example why we need that. In my first visit to Nigeria, which was a few years back, I was welcomed by this young patient here. His name was Gideon. And he presented me with this, I don't know where he got at that time, the photos, probably from one of the photos on the web, with this, "We love you." I was really quite impressed when I met with him, with his mother and with his father. 4 months following the visit, Gideon was hit by a truck and he had intracranial hemorrhage. There was no product in the country. So he passed away because there was nothing to treat Gideon. I was really quite affected by this. Everybody at the Federation was, and we started to think more about how we can really help the hemophilia community worldwide. And that led to, in the 2012, to have, during our World Congress in Paris, an appeal to the manufacturers to donate to the WFH Aid program. 2 years following this, two of the manufacturers, Biogen and Sobi, responded to our appeal, and they donate to us 100 million IUs annually of factor 8 and factor 9. Of course, the donation now came with a good shelf life. We know when it's going to come, and we know exactly the potency of the vials that we are going to get. So this helped us a lot in communicating with the countries in order to have with them programs how they are going to treat their patients. What is more important is more donors followed later in order to help the patients. So with this now big donations that coming to us, what we can achieve. First of all, the treaters at the other end, they can treat their patient according to the international standards and our treatment guidelines. In the past, they never always, if they had some factor concentrate, the patients mostly were undertreated. They just give them the minimum in order to a little bit stop the bleeding, and then they continue with other means. They have now the means to do corrective surgeries. In the past, they didn't have enough product to do corrective surgeries. The best that they could do is to have some products for life-threatening surgeries. They could do also now prophylactic treatment. Also in the past, with the minimum products, they didn't have the capacity to do prophylactic treatment. And now, as you will see, we see more and more patients under the age of 5 who are put on prophylactic treatment with factor concentrates. And at the end, we would demonstrate to health authorities the value of treating with factor concentrates in terms of the return to work, the return to school, the conservation of healthy joints, and all this. So countries and health authorities in countries could start to think about how we can sustain these good conditions that we managed to do with the humanitarian aid program from the WFH, and start to think to invest more in hemophilia care in their own countries. Now, this is a paper that we published about 4 or 5 years back. And we put also, this is a curve that you already saw. And we thought that with the donation coming to us, we're going to maintain the donation as is for the coming years between 2018, 2019, and 2020. But in fact, with more donors coming on the program, we managed to have more. And this now you will see, if you remember, we stopped here at this point with the other curves that I showed you. Luckily, we were very fortunate to have a very good now increase in the products that we are receiving. And in the year 2019, we managed in that one single year to donate almost 241 million IUs of factor concentrates. This drop here is for 2020, and that's the effect of the COVID-19 that we are going to talk about it later. But however, this year we are quite confident that we're going to start again, and maybe we are going to surpass the year 2019 in the amount of product that we are donating this year. I'm going to now show you a few KPIs, key performance indicators and examples from recipient countries. We mark the year 2016 as the year of what we call the expanded humanitarian aid program. So you will see now the results between 2016, 17, 18, 19, and 20. I'm going to lump them all together in a 5 years period. So I'm going to start first. Between 2016 and 2020, we managed to donate almost 882 million IUs of factor concentrate, with almost annual average of 177 million IUs. I mean, the number of the countries we reached during these 5 years is 73 countries. Although, of course, the number of the whole program since the start is 109 countries. And why is that? Because many countries out of these 109 now, they reached the phase of self-sufficiency. So they don't need us anymore to help them with factor concentrates. And that's what I talked about before, about sustainability, that now health authorities in some recipient countries, they really invest in hemophilia care, so they don't need us anymore. This is the map of the 109 countries that we managed to donate before. And you can see here that we have now many countries on the map that they don't need us anymore. Like Russia, for example, they are, if we take the scale of IU per capita, they are quite advanced, maybe more than 5 or more than 6 IU per capita. The same with Kazakhstan, and the same in some countries here in Europe. The other countries, of course, we still donate to them every year in the program. In terms of the number of people treated, so in the program between the year 2016 and 2020, we managed to reach more than 20,000 patients benefit of this donation that is coming, either if they had acute bleeds, or if they are on prophylaxis, or they had an intervention or surgical intervention. If I take the number of acute bleeds treated, it's really quite high. We reach about almost 260,000 acute bleeds with an annual average of 51,000 acute bleeds per year. I'm going to show you a few examples of these acute bleeds and how we managed to help. So this is a case from Cambodia, for example, of an intracranial bleeding that happened to a patient. He recovered with the treatment that was provided from the donations. However, and again, we're going to talk about this later, sometimes the late diagnosis will lead to some complications at the end. So this patient, unfortunately, he recovered, but with epilepsy that is still remaining. Another example from Pakistan, this guy had a motorcycle accident. He is from Peshawar in Pakistan, and he had a large bleeding from his abdomen that was treated with the donated product, and he recovered very well without any complications. An elbow hematoma in young patients from Myanmar. You can see the hematoma very well here, and on it's very also obvious on the X-ray. But again, with the treatment, he managed to go back to normal life completely. If we talk about prophylaxis, like I said, prophylaxis was completely zero in the past because the countries hardly found some factor concentrate to treat acute bleeds and life-threatening bleeds. With now more products available, we managed to put more patients on prophylaxis. So we have now about 2,270 individuals on prophylaxis, and this can be divided between prophylaxis using clotting factor concentrates and prophylaxis using the new treatment with emicizumab. So we have about 171 inhibitor patients and 295 non-inhibitor patients using the emicizumab treatment. The good thing is 70% of this number is children under 10 years of age. And that's really where we try to promote prophylaxis when the children are really active and they might have more bleeding, and that is going to lead to more joint problems in the future. So if we can protect them during these critical years, then they are going to have much better and healthier joints in the future. This is an example of a program in Pakistan that we started with our national member organization in Pakistan a few years back to put almost 60 patients or 60 children on prophylaxis, 30 from Lahore and 30 15 by 15 from Karachi and Rawalpindi. Of course, prophylaxis needs to be very well introduced to the community, and it needs to be very well bought by the family also. So before we started the prophylaxis, the treaters there started some kind of educational program for the patients and families to make sure that adherence is maximum, so that the people will really adhere to the program in order to make sure that prophylaxis is really good. What is even nicer now, in another visit that I did to Nigeria, I was also welcomed by now a few patients who are on prophylaxis waiting in the waiting room at the center in Enugu in Nigeria to get their prophylactic dose. In terms of surgeries, we managed in the last 5 years to support with donated product almost 3,800 surgeries. The number of countries so far performing surgeries is 26, because we still to train more of the people that they are doing surgeries in order to accept that surgeries can be done. There is no problem with doing surgeries on hemophilia patients. 429 surgeries were life and limb saving, and the number of major surgeries almost 1,065. Some examples also I'm going to show later. So you can see here that during these 5 years, the distribution of surgeries was almost the same. So surgeries are being very well and followed up by the treater. The green is the life and limb saving surgeries, like for example, surgeries on large hematomas or intra-abdominal or intracranial. With a few examples, this is a large hematoma from Manila in Philippines, where we can see before the surgery and after the surgery, how the patients managed to recover, and now he is back to normal completely. I remember this child from Egypt who he had a hematoma that affected his hand, and he had a wrist drop because of the hematoma. We managed to, of course, it was quite unfortunately late. So even when the hematoma was cured, he still had the wrist drop and the palsy of the nerve. So we had to support them with some also factor in order to do the operation. And he managed with the operation in order to a little bit extend his rest. And he is now almost 70% back to normal. Another example from India, Pune, with the patients who had a fracture that really was very hard to do it, but the surgeons in Pune in India managed to do the surgery with the donated product, and the person now is back to normal. I'm going to show two cases which also done by our colleague, Dr. Peter Quidis from Rochester. He assembled a team and helped in Nepal in doing few surgeries in Kathmandu in Nepal. So they did the first total knee replacement in Nepal ever. And the good thing that they trained the two doctors in Nepal on how to do this in the future. So Nepal didn't only benefit of the surgery and the product donation, but also for the training. And you can see here another operation that was done by Peter team on a large hematoma in the buttock. Here you can see on the CT scan how big is that, and even they did an angiogram too. And here Dr. Solimeno from Italy explaining the angiogram to the doctor from Nepal. We even help people to do synovectomies. I remember this case that we saw in Kenya, in Nairobi, Kenya in 2013. He had a large knee with chronic synovitis that needed some kind of synovectomy. We managed to give the product. Unfortunately, they didn't have at that time the knowledge to do either radiosynovectomy or at least chemical synovectomy. So they performed an open synovectomy. This photo was taken 2016, and then that one is taken 2019. And you can see that the person still have some flexion in the knee because he didn't go for an extensive physiotherapy after. His plan was to go for a commercial pilot. Unfortunately, because of this, he failed the medical exam for that. With the program also, we managed to do ITI. So we can see here that we have now around the world 70 patients who are going, some of them, of course, finished with the ITI. Number of countries doing the ITI are 6. And of course, with this, we did a lot of training. So during these 5 years, we managed to train almost 1,800 healthcare professionals from 65 countries. This is an example of ITI. This young man is an 8 years old boy from a small island in the Pacific called Kiribati. Unfortunately, he had 2 other brothers with inhibitors who died of bleeding. So he is the only left child with the family, and he also developed inhibitors. So with the Dr. Medeiros from Honolulu in Hawaii, we managed to provide the factor, and the patients did have the ITI. He finished the ITI, and now he is cleared from the inhibitors, and he is now responding. He is responding now to the treatment with factor VIII. Regarding the training, we managed to do a lot of training around the world before the COVID-19. So we did a lot of in-person training with our VP Medical, Vice President Medical, Dr. Glenn Pierce, who is very well known in the USA. And you can see here Dr. Glenn Pierce in one of the presentation in Myanmar in 2017 or in Armenia in 2016. We even did the training with ultrasound with Dr. Annette von Dreistry from San Diego on how to use the ultrasound for the early detection of bleeding in joints. And we hope that we are going to continue this during the year 2021, 22, 23. This is now after we started after the COVID-19, we started to do virtual training. And this is an example of the flyer that we do for the virtual training. This is, for example, we do now train frontline doctors and second-line treaters, in frontline doctors who are in the field, second-line treaters who are in the hospitals, for example, that we would like them to be much more knowledgeable about hemophilia, particularly for the doctors in the emergency room. So if I also take a quick look at the training that we did, you will see here the training of health professionals that we did in person until 2019. And then you will see here that in 2020, because of the COVID-19, we did a lot of virtual training. So we managed to reach really a quite high number in the virtual training. And that's a good lesson for us. So we hope that we're going to continue the virtual training in the future. And of course, we wouldn't have been able without thank you to all of these volunteers that they helped us in all the training that we did. We also managed to help refugees. As you know, around the world, there are a lot of crises around the world happening, and one of them is the one in Syria. So Amir is a refugee from Syria in Jordan who was hit by a bomb in south of Syria. So they rushed him to Jordan. He needed a quick operation because he was in coma because of a bleeding. Of course, north of Jordan, they had the knowledge, but they didn't have the factor concentrates, which we managed quickly to help them with through the national member organization in Amman in Jordan. Another example, another refugee, also Syrian refugee in Lebanon. This child was born in Lebanon after the crisis. And of course, he was diagnosed there with severe hemophilia A through the Lebanese Hemophilia Association, who helped him with the factor donations coming from us. And they even taught his father to self-inject or to give the product to the patients himself. We did also regional cooperation, or the donation helped in promoting regional cooperation. So for example, again, Yemen is another country who was torn by civil war. And this guy from Yemen had hematoma or in his lower abdomen. Unfortunately, he had also inhibitors. He needed a surgery, which was no way that it could be done in Yemen. He went to Pune in India, where Dr. Shashi Apte with his team in Pune, India, managed to help him. We donated to him the bypassing agent that they managed to do the operation. He sent us his photo later. Once he got back to Yemen, he is doing very well now. Another example, this child, Mutalla, is from Gambia, which is a small country in west of Africa. He was diagnosed as having hemophilia A, factor VIII deficiency. And he had bleeding, and they started treating him with cryoprecipitate. He never got better. So they contacted us, and we wanted just to make sure that the diagnosis is right. So we asked them to just go to the neighboring country, to Senegal, where they were met by Dr. Saliou Diop, the principal treater in Dakar, Senegal. He did again the diagnosis, and he found that the person had, the child had factor IX deficiency and not factor VIII deficiency. So they treated him with factor IX in Dakar, and they even gave him some factor IX going back home. And the last one is this child who had intracranial bleeding. He is from Kinshasa, from the Democratic Republic of Congo. And I remember this happened in the year 2019. And in fact, I was attending the NHF Congress, which was in Anaheim at that time. And when I received this call from Dr. Gaze Kondabi from DRC that we have this case, there was no way that we can rush a quick donation. So we asked another country, which is Congo Brazzaville, next to them, to ship them quickly some factor, which happened, and they managed to save the child. Now, of course, we faced a lot of challenges last year because of the COVID-19. With the lockdown of the countries and the lockdown or the change in many flights happenings. For example, this is a photo of a Lufthansa flight. As you can see here, now there are no seats for the passengers. Everything now is or was last year for the transportation of cargoes. The countries also faced a lot of challenges in clearing the products, and patients also faced challenges in visiting the HTCs because the HTCs were also closed because of the COVID-19 pandemic. This led to a huge increase in the cost of our shipping because now we have a longer transportation route that we need to go through, and that's why we needed to send the donations either in more isolated boxes, like you can see here with the blue boxes, or even in some cases we had to use environtainers in order to conserve the product that we send. In one incident also, there was no way to send to one country, which was Nepal. So we had to ask India to send some of the product from India to Nepal by land. Of course, to cross the border, we had to use a refrigerated truck, as you can see here. They had to seal the truck while it was going to pass through the borders between India and Nepal in order for the product to reach Nepal in the right time to treat the patient there. Having said that, we needed also to do a lot of preparations for the logistics for the patients or for our system also. So we managed to do or to establish a quality managed system, standard operation procedures from our end, and we did a lot of recruitment for new staff, including compliance managers, training managers to do the training. We did self-audit mechanism for our work also, and that's in order to ensure the full traceability of all products in case there is a possible recall in the future. And we established an online reporting database with a mobile app. And this here you can see a photo of the new mobile app that now treaters can use in order to report on the donated product. From the countries also, they needed to secure storage facilities with temperature monitoring because they are now having more products coming. In the past, they didn't have a lot of this, so that's very important. We needed to train them on the FIFO, first expires, first out, so they don't have any product is expired. We needed to train them on quarantine and destruction mechanism in case there is a product is expired. They needed to have also good registry record for the donated product and the treatment, and good reporting mechanism. So these are here two examples from two countries. One is Myanmar and one is Gabon, and you can see here the registry of how they take the leaflet of the product and put it in next to the patient, so we know exactly who got what, and they have now good storage system. Another example from Ivory Coast, you see also here how they have a very good registry for the utilization of the product. They have good refrigeration of the product, and even if they need to give product to some patients outside the centers, they also have a good system in order to conserve that. India also, you can see here this system. The green is the longest shelf life, the orange is the medium one, and the red is the one that has a short expiry date. So if they need to treat, they need to go immediately with the red one. And in case there is an expired product, they need to put it in a special fridge sealed as a quarantined product. Now, what still need to be done? Of course, there are still a lot that needs to be done. First of all, regarding the accurate diagnosis, effective outreach, the good identification of patients, and at the end, about inhibitors. So the lack of diagnosis, really, there's still a lack of expertise in diagnosing hemophilia, the lack of proper reagents, because many hospitals, they don't buy the deficient plasma, the standard deficient plasma for factor 8 and factor 9, or they are not registered in quality assessment scheme. This is an example of how we respond to this by doing a lot of training for the countries in order to improve diagnosis. The other thing is outreach. And this is an example from a country, Nigeria, where they managed to buy a car and they painted with the outreach. You can see here the outreach on the car. And they started going from one city to another, trying to identify more patients. And I asked them, let's do some kind of diagnosis, do some calculation, how this could cost. So we did do some relatively approximate cost, and we found that the cost of diagnosing one patient is really $100 if we take all that, which is not really that high a price. If we want to, let's say, diagnose maybe every year 20, 30, or even 50 patients per year, that's not going to be high price, but we need to follow up with them in order to make sure that this is possible. The identification of, or at least suspecting hemophilia is very important. And I still remember the case of this child from Nigeria who presented to the hospital with big hematoma. And the doctors they said, oh, you have a fibromyosarcoma and we will need to amputate your lower limb. The lady who is the president of the society contacted us, and we managed to instruct them and guide them on how to do with that. So we managed to save the limb of the child. And lastly, inhibitors also is very important. Usually treaters do not think of inhibitors, and laboratories do not test for inhibitors, and also they don't have the treatment for inhibitors. I still remember this case from Cambodia. While visiting them, the person said, oh, we are treating, the doctor said, we are treating this patient, but he is not really responding. And I immediately asked him, listen, if a person is not responding, you remember we talked about this yesterday during the presentation that we did. And he said, yeah, it's inhibitors. So they did the inhibitors and it was positive. Another case from Togo also, they circumcised this child and started to bleed, and they didn't know what to do. They contacted us also. We guided them. They did the inhibitor test, mixing studies, and they found that it was positive. And then they did the Bethesda assay, and it was 16. This is the photo of the circumcision, how it presented to them. Having said that, really, we won't be able to do all this without the support of all of our donors. So big thank you to all the manufacturers who are really supporting us. I'm gonna mention our founding visionary contributors for our extended humanitarian aid, Sanofi, Genzyme, and Sobi, our visionary contributors, which they are Bayer and Roche, our leadership contributors, Grifols, and our contributors, CSL Behring and Takeda. We wouldn't have been able to do all this without your help, so big thank you to you. I'm going to show you a few example testimonials, how this helped the countries also. This is a child, Isaac, from Uganda, who managed to finish his junior school without any absence from school due to bleeding. So he sent us this photo with his certificates saying thank you for helping him like this. Another letter from a father of a child from Togo who had also trauma on his right eye. He said, you cannot believe how I am pleased to see the smile again on the face of my child. But the best thing came from Philippines, from the city of Cebu, where the patients took all the empty boxes of the donated product and they built a Christmas tree, and they send us this and says the Lifesaver Christmas tree, which was really very, very nice of them doing this. So as a quick summary, the humanitarian aid program is currently the largest worldwide humanitarian aid program that channels clotting factor concentrates, established in the year 96. And then since the 96, we donated so far about 1.4 million IUs. We managed to reach 109 countries and more than 20,000 patients. And we witnessed, like I said, a rapid expansion in the last 5 years with more manufacturers coming on board. So what's the difference now between what happened with Gideon, who I mentioned at the beginning of this, and Elia? Elia is from the city of Enugu in the south of Nigeria. He had also hit by a truck, and he had intracranial bleeding and went into coma. But now things changed. Although there was no enough product in Enugu, but there was enough product in Kano in the north of Nigeria. And in less than 8 hours, the product was transferred from Kano to Enugu, and Elia was survived. So you see the difference between with no product and with products. And that reminds me of once what I heard from the president of the Society of Hemophilia in Nigeria. She said that for them, humanitarian program is between day and night. I like analogy. So this, I would say, WFH Humanitarian Program has boldly gone where no one has gone before, taking the Star Trek analogy. So looking at the future, we will continue our donations program according to the set criteria. We'll explore more possibility of donations from remaining manufacturers that they are producing CFCs. We're going to continue, hopefully, the virtual training. Like I mentioned, we have a quite peak in the training. We'll strengthen the compliance aspects by more training and monitoring, and explore possibility of making donations more sustainable through dialogue with health authorities in recipient countries. Lastly, what you can do to help us. I know now, after 3 days, we're going to have the celebration of Hemophilia Day next Saturday, the April 17. So I hope that by this, it's a call to everybody, especially in the USA, to get involved and to give today to our campaign in the USA through our affiliate there, the WFH USA. So thank you very much if you do that, and thank you for being with us today. And I think that's the last slide.
Great. Thank you so much, Dr. Haffar. We appreciate that. You have a lot of fans out there today, and there's several questions that have come in, so I'll start here. How does WFH leverage the humanitarian aid program to get governments in developing countries to purchase factor for longer-term sustainability of treatment?
Oh, that's really a good question, and it's the core of what we do with government. So we usually, like I mentioned in the first few slides that I showed, by showing governments how is effective treatment with factor concentrates, they're going to start to rethink that factor concentrates is very important. At the same time, through our work with WHO, we managed to keep factor 8 and factor 9 in the essential drug list of the WHO. So they are there. What we need is to convince government now to go for that. So we try to do some kind of, let's say, agreement with government where we tell them for the next 5 years, we're going to give you this amount of product. And this kind of product could go, let's say, decrease gradually in order for you to increase gradually and reach some kind of let's say, equilibrium with the amount of product that we give and the amount of product that you provide. Of course, we give product to countries where we know, I mean, the criteria of giving products is the country needs to be on the IU per capita scale less than 1. But most of the countries that we usually give is really at the bottom of that scale. So they are about 0.1 or less than 0.2 even, or less than 0.1. So we acknowledge that we will never reach a point where they will be completely self-sustained. But if we can reach with them that they can support 50% of the patients or 50% of the amount that we used to give, that's going to be good. So in summary, we try to reach with them agreement where we give them product, decrease that amount gradually, and for them, they need to increase the amount they purchase gradually.
Great, thank you. Next question comes in. If someone lives in a country where WFH does not support them, how does that individual get support?
I would say there is no country that we do not support because, now the WFH, we have 147 member countries, but we provide product to even more than to countries that they are not really members organization or members in the WFH, because we acknowledge for humanitarian aid, the country does not need to have a hemophilia society, and that hemophilia society is a member in there. What we need is to have a treater who knows how to treat, and we need to have a patient who was really good, who was accurately diagnosed. So we insist with these new countries that we don't know or they are not yet members to have to talk to the doctor and to have a copy of the diagnosis that of the diagnostic test that the patient got. I mean, by chance, this morning I was in contact with a country in Africa called Burundi, and Burundi, it's not a country with the it's not a member yet, but we had one patient with factor 9 in the capital. So I was talking to the doctor and I said, please, we need to have a copy of the diagnostic test. And I talked to the doctor to know more about the situation. Is the doctor knowledgeable about the how to treat and all that? And then we are going to give product.
Great. Thanks, Dr. Haffar. Next question comes in. Glenn Pierce has said that with populations growing at such a rate in developing countries, doesn't think it would be possible to supply sufficient clotting factor protein coming from recombinant DNA manufacturing to meet their demands. If this is the case, then what is the answer?
I mean, this is really also a great remark from Dr. Glenn Pierce, yeah, which is a valid remark. Now, so far, with the amount that is coming to us, we managed to, let's say, cover the need of the people in these developing countries. Now, for the future, we will need for sure to have more manufacturers coming on board in order to have more coming to us. The other things that we will need to explore also with novel therapies coming into the market, then that is going to alleviate some of the burden on the factor concentrate for treating, let's say, acute bleeds and all that. So hopefully when all of these novel therapies are in the market, we're going to have also more coming to us. And lastly, the gene therapy. Hopefully with the gene therapy coming into the market also, or approved in, we don't know how many years, we will manage also to get more gene therapy for the developing countries in order to help the patient there. So the answer would be is more manufacturers coming on board, novel therapies, and ultimately gene therapy.
Great. Thanks, Dr. Haffar. Next question is, how does WFH determine where the donation of factor goes?
So we have also, like I said, criteria regarding how we give the factor. So first of all, the country needs to be less than 1 IU per capita. We need to have a good diagnostic mechanism in the country to make sure that they have the capacity to diagnose hemophilia A and B. We need to have treaters who have also knowledge in using factor concentrates in order to treat hemophilia patients. And lastly, we need to have at least one lab that they can do mixing studies or testing for inhibitors, because we don't want also to treat patients and they develop inhibitors and the country doesn't have the capacity on this. So this is related to the country. And then so that's how we decide on the countries. And then the quantities is going to be according to the need of the country. So we usually ask the countries to provide us with the number of hemophilia patients they have there and the age distribution of these patients. And if they have any, let's say, long list of patients that they need surgeries and what kind of surgeries are planned for that, so we can plan with them in order to give them product for the surgeries. So we take into consideration the number of patients, how many patients will be on prophylaxis, how many patients will need surgeries, and if the countries has also knowledge in doing ITI, how many patients will need ITI. So we will know exactly the number of units that we will need to give to each country.
Great. Great, thanks, Dr. Haffar. Next question is, can you describe your experience of the early provision of Hemophilia as part of the program? How successful has this been adopted in relevant countries? What protocols are in place if a patient has a breakthrough bleed and or develops an inhibitor as a result of emergency factor in acute situations?
Yeah. Yes. So, I mean, we usually don't go and talk about a specific, let's say, product and all that. But since this is also a new product, I would just say that we follow always the manufacturer recommendation in this. So for the dosage, for the maintenance dose and all this, we follow that, and we provide very good training for the doctors, because again, you know, if we are going to give the emicizumab to one countries, we need the hemophilia community and the treaters at the other end to be knowledgeable about this new product. And since these people do not go to international congresses, they don't have access to, let's say, international scientific journal, they might not have good knowledge about the emicizumab itself. So we provide very good training for them to know on the know-how, and we monitor closely in order to make sure that they follow the recommended protocol, and for any, let's say, events that could happen or something like that.
Great. Next question comes in going virtual with the trainings, have there been any barriers with technology in some of the developing countries, and how did you overcome that?
In fact, for the technology, we didn't encounter a lot, let's say, of challenges here, because like, for example, with Zoom, you just need a reasonably strong internet in order to do a Zoom training. The challenges more that we faced was with the time difference, because, you know, if we do a training on taking into consideration the Eastern Coast time zone, we are 12 hours different from the people in Indonesia or Philippines or maybe in Cambodia. So this really was the biggest challenge that we faced. And at the same time, if we want to group countries together in order to do, let's say, regional training, then we are bringing countries with different time zone together. So the time zone was really the biggest challenge that we faced so far.
That's interesting, Dr. Haffar. Thank you. Next question is, how does the WFH Humanitarian Aid, does the WFH Humanitarian Aid Program also have supplies and treatments for patients with VWD? I think you mentioned something like that in your
yes.
In your presentation.
In fact, I put this mainly for the factor 8 and factor 9. But in fact, we receive also donations of product that contains factor von Willebrand in it, and we advise, because we get these questions from the countries and from the treaters, that I have these patients and I need factor for them. So yes, we receive product that contains factor von Willebrand, and we give it to patients, and we follow up also with them in order to make sure that they follow the protocols in treating these patients.
Great. We've got a couple more questions, Dr. Haffar. Next one is, how does the disparity of COVID vaccine distribution affect WFH plans in 2021 and beyond? Essentially, how does WFH plan on continuing to adapt to a changing world versus the US, since the vaccine distribution has been lacking in most developing countries?
Well, this is again a very valid and very good questions. So far, all of our, let's say, plan for going into the countries, either for training or for monitoring or anything, is on hold until we reach some kind of a stable situation regarding the COVID-19. We hope that by end of this year, at least for the people, our staff and our volunteer, they would be all vaccinated. So we might start our travel and going to some countries. Now, for the people at the other end, I know that it's very challenging and not everybody will be vaccinated in, let's say, India or Myanmar or Nigeria or Kenya. This might be a risk that we will need to see how we are going to cover this risk, and we will need to really look into this in much more details in order to see where we can go and what we can do with these countries.
Great.
It's quite premature to do really any kind of conclusion at this point.
Yeah, I think a lot of organizations are in that similar situation. The last question that came in is, can the WFH Humanitarian Aid Program accept expired factor?
No, this is one of our because I mentioned also that we developed and established quality management system and standard operation procedures. We want really our program to be very much credible. So we don't accept expired product, and even we don't accept, let's say, nearly expired products. So according to our policy, we need to have minimum 6 months in order to accept the product. And at the same time, countries at the other end, they started to put also more restrictions and regulations regarding accepting products. So many countries now, either they ask for 1 year minimum shelf life in order to accept a donated product, or 50% of the total shelf life of the product. Because as you know, there are now some product in the market that the total shelf life of the product is either 30 months or 36, which means that some countries, they might accept any product of, if it's the shelf life of the products is 36, that it's less than 18 months. For these countries, we are trying also to negotiate with them in order to convince them that you can accept the product less than 1 year of expiry date or shelf life, as long as it's going to be used before expiry date. Again, just by chance today, we were talking to one of the treaters in Sri Lanka, because we sent them a product, so they accepted it, but because of the delay of the COVID-19, when the product arrived and it's going to be cleared through customs, the shelf life now is less than 1 year. And the Department of Health there started to question, oh, this one now is less than 1 year. We might not be able to clear it or something like this. So that the principal treater from the hospital in Colombo in Sri Lanka wrote a letter to the Department of Health explaining the situation and assuring them that the product is going to be used in the coming 5 to 6 months. So it is far beyond the expiry date of the product.
Thanks, Dr. Haffar. We do have one more that came in, and this might be a good one to end on since we're right up against the hour here, sir. But this one, it comes in and says, besides monetary support, how can individuals advocate or support the efforts of WFH?
Oh, that's really very, very, very good. As I mentioned, they can join our campaign in the USA through WFH USA. That's for sure. It's a very good thing. Now, the other thing is we need the voice of the hemophilia community in the USA to support our efforts with the manufacturers, either by convincing other manufacturers to join the program, or even the current manufacturers to believe more in us and give more to the program. So that's why we need a strong voice within the USA to the manufacturers in order to continue supporting the program. Because again, as you know, we now have agreements with all of our manufacturers for either 3-5 years, something like this. But we need always to have these renewed regular basis in order to keep this, taking into consideration that we are really working with recipient countries in order to establish some kind of sustainability from the countries to support their own patients also.
Great. Well, Dr. Haffar, I'd like to thank you for being with us today and taking the time to join us this afternoon. We really appreciate you presenting on the Humanitarian Aid Program. Very compelling. We appreciate your time and expertise, and I'd also like to thank each and every one of you for joining us. Please note that this recorded webinar will be available on Friday, April 16th at hemophilia.org under the Events tab with all of our other archived webinars. Also available in the Events tab is our upcoming schedule of our weekly Wednesday webinar series. Thank you once again for joining us, and Dr. Haffar, thanks for being here and presenting to us.
Thank you very much. Thank you, and thanks for all participants, and thank for the active questions that came. It was really my pleasure. Thank you.
Thank you. Have a good day, sir.
Thank you.